So without further ado, let's go to the second topic of the day, where we're going to be seeing what actually causes acne. Because people always associate acne with having oily skin. Okay, but are there any other factors that can make a person more predisposed to acne? We're going to listen from Dr. Evelyn. Okay, so what are the pathogenesis? Okay, and how do we diagnose acne? Do we need to do any tests, okay, any investigation to diagnose acne, or is it merely just clinical diagnosis? And how do we assess acne? Because assessment is a very important part of acne management, without which we can't decide which treatment we're going to start patient on. Now, let me introduce Dr. Evelyn before she starts. Dr. Evelyn Yap Wen Yi is a consultant dermatologist practicing in Mahkota Medical Center, Melaka. So she will be highlighting the pathogenesis, diagnosis, and assessment in acne vulgaris. So Dr. Evelyn, the floor is yours.
Thank you so much, Dr. Azura, for the kind introduction. And thank you all of you who are present online for joining us today on a Saturday afternoon for this workshop. So I'm going to continue from Dr. Norliza to talk about pathogenesis, diagnosis, and assessment in acne vulgaris patients. So these are the learning objectives of this module. This module aims to help everyone understand the pathogenesis of acne vulgaris, and it also helps everyone to be able to diagnose acne vulgaris confidently. It helps to identify the differential diagnosis and the tests that may be done in order to rule out the differential diagnosis that may be associated in acne vulgaris patients. And lastly, in this module here, I will be talking about CAS, which is the Comprehensive Assessment Severity Scale, in the assessment of severity of acne vulgaris in patients. So let's start off with pathogenesis of acne vulgaris. So there are four main pathways that are involved in the pathogenesis of acne vulgaris. First up, we have increased sebum production. And this increased sebum production, along with the dead skin cells, will then accumulate in the hair follicle, in the pores, which eventually lead to follicular clogging. So when you have follicular clogging, the follicular content will then be colonized by this bacteria called Cutibacterium acnes. And as time goes by, the colonization by Cutibacterium acnes will eventually lead to inflammation and release of inflammatory mediators. So I mentioned earlier that Cutibacterium acnes plays a pivotal role in the pathogenesis of acne vulgaris. However, it is not just the presence of Cutibacterium acnes that matters, but in fact, it is the loss of diversity of C. acnes phylotype that is more important in the pathogenesis of acne vulgaris. So in healthy skin, studies have found that the frequency of this specific phylotype, the 1A1 phylotype, is about 40%. And then this is followed by a mix of other phylotypes, including phylotypes 2, phylotypes 3, 1B, and 1A2. But things are a little bit different in acne inflammatory lesions, where instead of 40%, the 1A1 phylotype of the Cutibacterium acnes was found to represent about 70% of all the C. acnes phylotypes. Now, why are we so concerned about the phylotypes of C. acnes? It is because this particular phylotype, the phylotype 1A1, is known to produce larger levels of virulence. It is able to generate reactive oxygen species and also free radicals that in turn damage the keratinocytes and therefore support perifollicular inflammation in acne. So that is why we are concerned about C. acnes nowadays. Comes to diagnosis, I believe all that is present today generally will be able to diagnose acne. So it is a clinical diagnosis made based on the presence of non-inflammatory lesions such as open and closed comedones, and also inflammatory lesions such as papules, pustules, nodules, and cysts. And the common areas affected include the face and also the trunk. So these are some images showing the non-inflammatory lesions. On your left, we have open comedones, which is also known as blackheads amongst laymen. And then on your right, you have closed comedones, which are known as whiteheads among the common population. So then moving on, we have also inflammatory lesions. On your left, you see many papules and pustules. Papules are generally raised lesions measuring less than 1 centimeter, whereas pustules are papules with presence of pus content. So on your right, you also have some other inflammatory lesions, which are pustules. Nodules are where the raised lesion is more than 1 centimeter. And you also have cysts, where the lesions tend to be fluctuant as compared to nodules and papules. So moving on to investigation. Do we need to do any investigation in acne patients? Well, I would have to say it is rarely needed. So, but in certain cases, some of these patients may require certain investigations, especially when we want to rule out the other diseases which may be associated with acne. For instance, polycystic ovarian syndrome, Cushing's syndrome, or even androgen secreting tumor. What about microbiology tests? Since I mentioned in my pathogenesis slide that C. acnes is such an important bacteria in causing acne, right? Should we routinely swab all patients to look for C. acnes then? Actually, that is not necessary also because, clinically we can tell confidently it is acne. There is no point for us to confirm C. acnes because it doesn't help. It doesn't add value to our management of our patients. However, in certain patients, I do swab cultures on and off. For instance, in this picture here, this is a patient of mine who no doubt has underlying acne vulgaris, but she developed sudden eruptions of many pustules after going to a beautician for treatment. So in this case, I was suspecting gram-negative folliculitis, and true enough, when the swab culture came back, it grew Pseudomonas aeruginosa. And so these are the instances where, a swab culture may be useful, especially in our acne patients. It is when we want to exclude certain infections that may look like acne vulgaris. Okay, moving on. Endocrinological testing. So endocrinology evaluation is indicated in patients with clinical features or with a history of hyperandrogenism. So at the moment, polycystic ovarian syndrome, PCOS, is the most common cause of elevated androgens of ovarian origin. And for that reason, when you're seeing your acne patients, it is always good to take note and see whether or not do they have features that suggest hyperandrogenism. So apart from acne, do they have hirsutism? Are they overweight? Do they have irregular menses? So these are important questions that we need to cover when we see our acne patients. And if you think they do have symptoms or signs that suggest hyperandrogenism, then referral to a gynecologist for hormonal assessment and pelvic ultrasound is helpful in confirming PCOS. Okay, the last part of this talk will be on CAS, Comprehensive Assessment Severity Scale. So there are many severity assessments tools that has been validated, but our CPG group actually recommends using this Comprehensive Assessment Severity Scale in order to grade patients' severity. This is a validated tool and it is very simple to use in clinical practice. It takes you only a few seconds, less than 5 seconds in fact. So based on this CAS scoring, okay, there are actually 6 categories ranging from 0 to 5, clear to very severe. So clear means, there are no lesions or maybe there are a few but barely noticeable ones. Almost clear is scored 1. It is hardly visible from 2.5 meters away. So 2.5 meters, to make things simpler, is about 4 arms breadth away. So if at 4 arms breadth you can hardly see anything, then it's almost clear. Or sometimes the patients may have a few scattered comedones, very small papules, and very few pustules, nothing really major. Okay, mild is easily recognizable. Less than half of the affected area is involved. There may be many comedones, there may be papules, and there may be pustules. Moderate is when more than half of the affected area is involved. There may be numerous comedones, papules, and pustules, more than in mild cases. Severe is where the entire area is involved and the face is covered with comedones, numerous pustules and papules, a few nodules, and even cysts. Whereas very severe is grade 5, indicates highly inflammatory acne covering the affected area with nodules and cysts present. So these are some pictures to illustrate what I meant by CAS 0 clear. So there are no lesions to barely noticeable ones. So you can see in all these pictures, the patient hardly have any acne, maybe a few acne scars, but active acne, you don't see much. So CAS1 is almost clear, from forearm's breadth. So you do see a little bit of acne maybe on the forehead, but again, this is nothing really major. They may have a few scattered comedones or a few small papules and very few pustules. So mild is easily recognizable, but involving less than half of the affected areas. There may be numerous comedones, papules, and pustules. On the side view of these patients tend to look seems quite bad, but if you look into it carefully, she doesn't really have much active acne. But she does have very significant post-inflammatory hyperpigmentation, which is one of the complications of acne, which I will be covering in my subsequent lecture. So then we have moderate. Okay, this is where more than half of the affected area is involved. There are numerous comedones, papules, and pustules. Definitely, you can see very obvious acne lesions involving more than half of the affected area. So severe CAS4 is where the entire area is involved. You can see this is highly inflammatory acne. There are a lot of comedones, there are numerous pustules and papules, and there are few nodules and cysts. Whereas this is CAS5, also highly inflammatory, and there are a lot of cysts, if you can see, on the forehead, on the right cheek, on the left cheek. So this is, highly inflammatory acne covering the affected area with nodules and cysts present. So I've reached the end of my talk, of my first lecture. So basically the take-home message first, the pathogenesis of acne vulgaris involve four main mechanisms. And these four main mechanisms are important for you to bear in mind because it helps to understand why certain treatment are being used in the treatment lecture later. So the four main mechanisms are firstly, follicular hyperkeratinization, increased sebum production, colonization by Cutibacterium acnes, and lastly, inflammation. So acne vulgaris is diagnosed clinically based on the presence of non-inflammatory lesions and inflammatory lesions. And CAS, the Comprehensive Assessment Severity Scale, is recommended for the assessment of acne severity as it is simple to be used in clinical setting. So with that, okay, I end my first lecture here and I thank you all for your attention.
Thank you very much, Dr. Evelyn, for highlighting the important pathogenesis of acne. First, definitely we have to understand what is the pathogenesis of acne. Once we know what causes acne, then only we can go into the treatment.